I'm going to present you the different positioning for a patient prone on a Raphael table. And the progressive positioning. And what do I mean by progressive? I mean that for a lumbosacral type of treatment, we're going to come from a distal type of anchorage to go to a more proximal type of anchorage. And when we don't know exactly how the patient responds, it's usually a good clinical fact to start progressively. So now you don't have to go through every steps. We have 5 steps in it. Let's take a look at them. And remember, between the steps, we may want to have the patient stand up, check him how he feels and what is his functionality, if we have an improvement or not. And all these are done during the first visit. And what we want to establish is basically the best treatment for that patient during the first and second visits sometimes. Once we have done that, the biggest chunk of the protocol of treatment has been achieved. So we're going to start by positioning our table to make it ready for the patient. So I've installed here the lumbar belt, which is the widest one. Then I'm also installed the thoracic belt, which is the narrowest one. And we do that so we do not have to move the patient as we change the anchoring. I lower my cervical piece a little bit, like that. And what I want to create a cephalad arc of tension, quite strong. It's why I have the cephalad headpiece a bit down. And then later on, I will align a little bit the stretching bar. Now I'm going to raise this 2 handles up, so it's a little bit more comfortable for the patient as he lay down. All right, Laura, would you mind to come? And you're going to lay down, face down. Beautiful. So I may want to position my patient so it fits a bit better on the table. So here, I'm going to pull her up gently. Beautiful. Then I'm going to step up my anchoring on the feet. My anchoring is done on the feet. I'm going to extend a little bit. Can you hold that bar? Hold that bar. Are you comfortable like that? Beautiful. And I'm going to rest that bar. Now we are done. And this patient is going to be able to control the traction that she has in the low back. And if it feels uncomfortable, obviously she's going to tell us, or she's going to let the bar go to not worsen the problem. So it's self-controlled by the patient, which makes it a very, very safe protocol to start up with. As I perform an axial distraction on the patient, I will oscillate this caudal section right or left, depending on the symptomatology of the patient. Generally speaking, when you have a sciatica on the right, by leaning on the opposite side, it helps the pain, but not always. But I will find out prior to put the patient down which side leaning is helping her, and we use the same side on the table and lock it. I will go with traction. I do not need to have an incremental traction when the patient holds like that the bar, because she can let it go. So incremental really is a little bit too much here. I want to speed up things around. So I'm not going to use an incremental traction. I'm just going to select a good amount of traction, roughly 1/3 of the distance here on the, and I'm going to click start. Are you feeling comfortable?
Yes.
And I'm going to ask the patient, pull yourself up a little bit. Can you pull yourself up with your arm? Okay, good. Let it go. And tell me how it feels if you have no pain with that, okay? Okay, once we have done this, I'm going to stop. And I'm going to go to another type of testing. So then I'm going to unlock, unanchor both ankles. So I take that off. Beautiful. And I'm going to use the pelvic strap on this patient. So the pelvic strap to hold her well. Beautiful. I will raise the lower part of the leg up, which will have as a function basically to relax the posterior thigh muscle, and I will start again my traction. I will do that a few times and check how the patient feels, and I may ask her to stand up and to start to perform some motion to see if she improved or not. I'm going now to raise the pelvic section in order to increase the lumbar lordosis on this patient. And that's going to allow me to know a little bit the positioning of the disc in relation to the nerve root. So most of the people will feel better in this latter position. I'm going to ask you to raise up your pelvis, and I'm going to go under the belt and slide this down. Beautiful. I've increased the lumbar lordosis, and I'm going to lock this section again. Beautiful. And we're going to go again for a little traction. Hold your hand up, beautiful. And we stretch her a few times and ask her how she feels. We can even check out how she feels as we put the pressure on the low back. Now we're going to just anchor also the thoracic section. And usually, we will leave the feet as is and start again the traction. We can also test the lateral bending as we go. Are you okay?
Yes, sir.
We have now a patient with a pelvis anchorage, a thoracic anchorage. We have raised a little bit the pelvic station to increase the lumbar lordosis. We can do even much better to increase that lumbar lordosis. We can put the compression on top of it. And that's what we're going to do right now. So I'm going to move a little bit the thoracic section. Very good. So I have this at the right dimension. And I just flip it down to to increase the tension. And I will screw it a little bit, and we have something very tight. And I will go again for a few tractions. And now we have a nice compression of the spine, lumbar spine in extension, a traction with 2 anchorage points, pelvis and thoracic, and we have the feet semi-bent to basically increase even more the lumbar lordosis. Now we can also use a flexion with that. I'm not putting the flexion, we are trying currently only axial distraction, but the flexion obviously will go a little later on.